Now let's go over Basic and Applied Human Anatomy and Development 2018 final exam. We are going to go through section A in this session. What does the term invasion mean? Now, invasion means you move your foot such that the sole of your foot, which is the bottom of your foot, faces medially. So the answer is B here. While if the sole of your foot faces laterally, that is going to be evasion. Number two, which of the following terms best describe the movement of the great toe towards the rest of the toes? When you are moving any body parts towards others, that is adduction. You're trying to add. So the answer is adduction. When you're talking about protraction, it's just trying to remove something. For example, trying to remove your tongue outwards, or your eyes, you're trying to bring them outwards. That's protraction. Pronation is where the palm of your hand faces downwards. What does the term perfocal mean? Now, when you're talking about perfocal is where you are changing the objective lens, but you are not refocusing. All right, so that is option C. Which of the following is correct regarding the term resolving power? When you're talking about resolving power of a microscope, is just the minimum distance at which you are able to see two different objects as being separate, and it is determined by the objective lens. So option A, the ocular lens determines the resolving power. That is not true. It's the objective lens. B, it is the largest distance between two particles at which they appear as separate objects. That's also not true. It is actually the minimum distance. It is the ability of the microscope to magnify many objects at the same time. That is not true. The objective with a higher magnification has higher resolving power. So that is true. Objectives, lenses with high magnification are going to have a high resolving power. Number five, which of the following statements right describes a plane? Now, a plane is basically an imaginary line that is drawn on the board. You have got the sagittal plane, the coronal plane, you have got also the transverse planes, right? So A, it is a solid line that is drawn in the body of a subject. That's not a solid line. B, it is the cut surface of the body, really not. C, the coronal and the midi sagittal sections are examples. They are not sections, these are just planes, so that's not true. An imaginary flat surface dividing the body. So that is it. An imaginary flat surface dividing the body. Which of the following organelles are abundant in fibroblasts? Now, fibroblasts are cells which make extracellular matrix. So, which one of these organelles is involved in the formation of extracellular matrix? It's the rough endoplasmic reticulum. So, that is the answer. Dash are numerous in cells that are involved in detoxification. Now, detoxification is the function of the smooth endoplasmic reticulum among other functions. Ribosomes make proteins, right? So the answer is detoxification. The fluid mosaic describes the plasma membrane as consisting of. Fluid mosaic is going to tell us that the plasma membrane has got a lipid bilayer that has got proteins in it, and those proteins are actually not stagnant. They are able to move around like that. So option A, two layers of phospholipid with protein in between them, a protein bilayer with embedded phospholipid, a phospholipid single layer with embedded protein, a phospholipid bilayer with proteins embedded in it. So the best answer here is D. You have got a phospholipid bilayer that has got proteins embedded in it which are able to move. Which statement is correct about the cell cycle? Now, in the cell cycle, we have got two phases. We have got the I phase or the interphase and the M phase, which is either mitosis or meiosis. In the I phase, we're going to have G1. Let me just write that. So we can divide it as having the I and the M. Now we are going to start with the M phase. The M phase is going to go to G1. G1 is going to go to the S phase. The S phase is going to go to G2, and then from G2 we are going to go back to M. So M is where the cell is dividing. That's mitosis or meiosis. This is where we find the prophase, metaphase, anaphase, telophase. G1 is where the cell starts to grow and also duplicate its organelles. Now, if the cell does not want to undergo cell division, it is going to go into G0. G0, this is the resting phase of the cell. And then S phase is where the cell undergoes DNA replication, replicating its DNA. G2 is just to make sure that all the organelles have grown, so it is further growth. And then you have got the M phase. So if you look at this in G1 phase, the cells are resting. Resting is G0. In M phase, organelles mature. The maturity of organelles is going to be happening in G2. G1, of course, they were growing and also maturing, and also in G2 to just make sure that they are fully grown. G0, DNA is duplicated. Duplication of DNA is happening in the S phase. G2, karyokinesis happens. Now, karyokinesis is the separation of the cytoplasm, actually the nucleus. Okay, because cytoplasm is cytokinesis. Now, this is going to be happening in the cell division. What happens is that after your cells divide, the nucleus is also going to divide, and then you are going to have a single cell. After that, now the cell is also going to divide so that you can have a nucleus with each cell. So this means that this option is also not true. So for this question, I don't know what they wanted us to pick. Otherwise, there is nothing that would be fully correct here. Question number 10. Regarding the cell, which of the following is not true? Neutrophils contain zymogenic granules. This one is true. Neutrophils contain granules. Now, zymogenic means they're inactive. Macrophages have numerous lysosomes. That is also true. We know that macrophages are involved in the phagocytosis, so you need lysosomes to be able to, after you phagocytose a cell, lysosomes will produce these enzymes to be able to destroy what has been phagocytosed. Skeletal muscles have prominent nucleolus. This is not true. Even if they have got a nucleus, skeletal muscles, the nucleolus is not that prominent. Basophils complement mast cells in terms of function. This is true. Basophils and mast cells contain receptors for IgE, and these are involved in allergic reactions. So the answer is C, which is the one which is not correct. Which of the following is correct concerning malepithelial cells? Now, malepithelial cells are going to be found with the cells which secrete things. So these ones are going to be contractile. So when they contract, those cells which have got what they're supposed to secrete will be able now to be able to secrete what they're supposed to. Okay, so are scattered among secretory cells. Dash line is seen as a line of demarcation between lighter flexor and the darker extensor parts of the skin of limbs. Fatcher's line, wrinkle lines, occupational lines, and then contour lines. So lines which are going to be seen between darker portions and lighter portions of extensor parts of the skin are known as Fatcher lines. So what you're going to be able to see is, let's say this is your leg. Okay, you are going to see there will be some kind of division. If this part of the body is light, this part of the body is dark, you are going to see some kind of line which is dividing these two regions. That's a fascia line. Regarding the resting skin tension lines, which statement is correct? Are inappropriate for surgical incision. This is not true. These tension lines are very much appropriate. For example, in the abdomen, you'll see that lines go like this. So even when you want to make an incision, when you want to cut in the abdomen, you are going to cut parallel to this, because if you cut like this, it will be very hard for them to be able to heal. So they are very necessary. Option B, pinching at right angle will produce more tension lines. This is true. Tension lines, when you pinch them at right angle, they'll produce more. Are altered by contraction of muscles deep to them. Actually, these tension lines are going to be produced by the, not really the muscles, but produced by the dermis, which is under this the on under the skin. That is what produces these types of these tension lines, because the dermis has got the papillary layer, and those, when they do contract, will be able to form these tension lines. Are the same as crazial lines? That is not true. So the answer here is going to be, which one is correct? It's going to be this one. Skin creases limited to the conified or uppermost layer of the epidermis layer are termed as. Now, skin creases which are limited to the uppermost layer. Okay, the uppermost layer, you have got, let's say for example, you are talking about the question number 15. Brenner's glands are an example of, when you talk about, okay, let's go on with 14. Skin creases limited to the conified. Skin creases limited to the conified or the uppermost layer of the epidermis layer are termed as the uppermost layer, which is the stratum corneum. When you look at these skin creases, these are just lines which make our skin to those lines which we are just able to see on the skin. So the primary skin creases, these are basically the ones which you are going to be able to see just on top, okay, just on top of the skin layer. So that is the primary. Secondary ones, these ones are going to be, they'll go a bit, they'll result when the primary creases are not controlled, maybe due to some form of infection or something like that. Okay, so I think the best one that we can pick for this one is the primary, because we're talking about just the uppermost layer of the skin. Brenner's glands are an example of. Brenner's glands are an example of simple acini, simple branched acini, compound branched tubular, compound tubular acini. Now, these Brenner's glands are compound branched glands. Okay, they are compound branched glands. They are found in the GIT. Which of the following structure gives the nucleus its structural support? Now, the structural support of the nucleus is given by what is known as the nuclear lamina. And the nuclear lamina is made up of laminins, meaning that the best we can pick is the laminin here. Which of the following statements regarding cytoskeleton is correct? When you're talking about cytoskeleton is going to have is going to be made up of microfilaments. We also have intermediate filaments. We also have microtubules. So when you look at this, the microfilaments, also known as actin filaments, these are just about 7 nanometers in diameter, and they are made up of actin protein. Intermediate filaments, these are about 10 nanometers. They are made up of different proteins. Macrotubules, these are about 25 nanometers in diameter, and they are made up of the protein tubulin. So, which of the following is true about regarding cytoskeleton? The intermediate filament are the smallest. They are not the smallest. The smallest are going to be the microfilaments. Microfilaments anchor in position some plasma membrane proteins. Okay, how about this one? This is actually going to be true. We are going to be able to anchor in position some kind of proteins. I think, for example, you have got actin filaments in muscles, and they are going to be able to anchor to other muscles, to anchor other structures like that. A pair of centrosomes make up centriole. Now, this is not true. Two centrioles will be making up a centrosome, not a pair of centrosomes. Basal bodies in a cilium are made up of 9 pairs of microtubules. That is not true, though basal bodies are just modified microtubules, but that is not true. Which of the following epithelium lines the cornea of the eye? The cornea of the eye is lined by simple squamous epithelium. The cornea of the eye is lined by simple squamous epithelium. Okay. Which of the following epithelium lines the cornea of the eye. Now, the cornea of the eye is going to be lined up by stratified epithelium, and that should be the stratified epithelium that is watery. So it shouldn't be keratinized. That is non-keratinized. Which of the following epithelium lines the pleural cavity? Pleural cavity is lined by simple squamous epithelium. Which of the following glands release their secretory product by the apocrine mode of secretion? When we're talking about modes of secretions, we have got different ones. The apocrine we have got apocrine, merocrine, which is also known as ecrine. We also have holocrine. So, for example, mammary glands, including also sweat glands, which are found in the axilla and in the external genitalia, these are going to release by the apocrine method, and then sebaceous glands by the holocrine, they release all their content by exocytosis. And then by ecrine, also known as merocrine, we have got the pancreas and also some salivary glands like that. So then what would be the answer? Which one is this? By apocrine, what have we said? Apocrine, we have got sweaty glands, we have got mammary glands, sweat glands to be specific, those which are found in the axilla and in the external genitalia. So this is going to be correct. A. And then number 21, with regard to the lining of the ileum, the following are true except the lining of the ileum. It is lined by simple columnar epithelium. This is true. Simple columnar. It has multicellular granular structures, goblet cells. Now, it has multicellular granular structures, goblet cells. This statement is not true. Goblet cells are not multicellular. They are the only glands which are unicellular. It has simple straight tubular glands, crypts of Lieberkühn. This is true. Crypts of Lieberkühn are straight, simple, straight tubular. It's important to take note because in another question it can come as a question like that. Paneth cells are present at the base of the intestinal glands. This is also true. Okay. Which of the following epithelia withstands desiccation? Which one withstands desiccation? So A, stratified squamous non-keratinized, pseudo-stratified columnar with stereocelia, stratified squamous keratinized, pseudo-stratified columnar ciliated. So the answer here is going to be stratified squamous keratinized. When we're talking about desiccation, we're just talking about wetness. Which one stands wetness? So the keratinized epithelium is not wet. All right, it doesn't have, it is not watery. Which of the following is a follicular endocrine gland? Now, of these, the thyroid gland does have follicles. The pituitary gland is going to have the exocrine part and also the endocrine part. So when you talk about the endocrine, the one which releases its contents, that's endo, into the blood system, and the exocrine, the one which does not release its contents. So I've got the highlights of Langerhans. Those we can also call them the follicles. Okay, and then we have got the alpha cells, the beta cells, which will be able to produce the glucagon, the insulin, and those. Actually, I'm mentioning another structure. This is not the pancreas. This is the pituitary. Okay, I was supposed to be mentioning about the pancreas. That's the one which has got the exocrine part and the endocrine part. So, because we are specific for this question, we're talking about those which have got follicles and the endocrine. The thyroid gland is endocrine, but it also has follicles. The pancreas is both endocrine and exocrine. These others, the adrenal gland. The adrenal gland will be able to release its content into blood, so meaning it is endocrine also. But does it have follicles? Really not. Same with the pituitary gland. The pituitary gland will release its content into blood. That is also endocrine. But does it have follicles? That should be there. That's why we have picked the thyroid. Which of the following cells have receptors for IgE on their surface? Immunoglobulin E. So we said basophils and mast cells are the only ones which have got receptors for IgE. Concerning the perichondrium, which of the following statement is correct? It consists of collagen type 2. Now, perichondrium does not have collagen type 2. So this is not going to be correct. It has an inner cell layer consisting of chondrocytes. This is not correct. The inner cell layer of the perichondrium has got chondroblasts, not chondrocytes. It makes up the outer covering of the fibrocartilage. Okay, is this true? This is not true. Fibrocartilage does not have a perichondrium unless elastic cartilage and hyaline cartilage. It has progenitor cells which become chondroblasts. This is true. It does have progenitor cells which are going to form chondroblasts which build or make this cartilage. Cartilage found in the external acoustic meatus is characterized by, the first thing is, what type of cartilage is found in the external acoustic meatus? That is elastic cartilage. So A, cell nests of not more than two chondrocytes. This is true. Elastic cartilage is going to have cell nests with either one or two chondrocytes, okay, in each lacunae. Absence of perichondrium. This is not true. That is because elastic cartilage has got perichondrium, collagen type 2 only. Okay, collagen type 2 only. This is not true. Elastic cartilage has got collagen type 2. It also has got elastin, the same type of cartilage as that one which is found in the pubic symphysis. Is this true? This is not true. External acoustic meatus, we have said that the cartilage is, we have said that the cartilage here is elastic cartilage, but pubic symphysis, it is hyaline cartilage. Number 27, with cartilage regard to epiphyseal, which of the following is true? We know that the cartilage on the epiphyseal plate is the hyaline cartilage. It is fibrocartilage. That is not true. Its arrest has no net effect on the growth of long bone. That is not true. If you do arrest this cartilage, it means that it will affect the growth of long bones because it is on the growth place where these bones are going to be able to grow. It is radiolucent. This is true. In other words, it is translucent when it comes to radio X-rays. Okay, it is translucent, like you can look through them. The hyaline cartilage. Its resting stage is characterized by osteocytes. Is that true? That is not true. Which are okay? So the best answer here then would be a C. All right, to be C. When you are talking about, why have I said D is not correct? This is cartilage, and when you're talking about osteocytes, these are cells which are found in bone. Unless if we had said the chondrocytes, the resting stage has chondrocytes, not osteocytes. This is not bone, this is cartilage. Which of the following statement is correct about cartilage? The territorial matrix is not the matrix that immediately surrounds the lacuna. The interterritorial matrix has no staining difference with the territorial matrix. Territorial matrix is rich in glycosaminoglycans. Collagen fibers are less abundant in the interterritorial matrix. Now, if we have got, say, this is a lacuna, this is another lacuna, and it has got the chondrocytes. The region near this lacuna immediately, that is what we call as the territorial matrix. Same also here, you are going to have the territorial matrix. Now, the region between these territorial matrix is going to be known as the interterritorial matrix. So these two regions are going to stand differently. The territorial matrix and the interterritorial matrix will be able to stand differently. To be specific, the territorial matrix is going to have a lot of glycosaminoglycans, so they are going to stand even more basophilic. Okay, you are going to see them like more dark like that. So that's the answer C. Compact bone is characterized by one of the following. When you're talking about compact bone, osteon, also known as Havesian canal. Of course, compact bone has got an osteon, but the other name for osteon is not Havesian canal, but Havesian system. So that is why this one is wrong, because the Havesian canal is just the middle of the bone. A cement line surrounding each Havesian system. This is true. Each Havesian system is going to have a cement line surrounding it. Osteocytes actively secreting extracellular matrix. Now, is it the osteocytes which secrete extracellular matrix? So it is not the osteocytes. Okay, supposed to be the fibroblasts which will be able to secrete extracellular matrix. Okay, or if you are not talking about fibroblasts, at least those things which are ending with a blast at the end, they're the ones which do secrete, like chondroblast, osteoblast, not the sites. So osteoblast, not osteocytes. And then interconnected trabeculae of bone. Compact bone is characterized by interconnected trabeculae of bone. This is not true. Trabeculae is not found in number 30. One of the following is not true concerning woven bone. Now, just like we have got compact bone and spongy bone, we have got also woven bone and lamellar bone. When you're talking about the woven bone, this is the bone that is going to produce osteoid in case, let's say, a bone has broken. So woven bone is the bone that will appear to produce osteoid. Osteoid is the first uh, organic matrix which is going to be produced so that a bone can develop from there, right? So this one is going to be found in the fetus, and then it is going to be replaced by lamellar bone. Okay, and again what will happen is that, let's say when you hit yourself, the bone is injured like that, where the bone has to be replaced, you're going to find woven bone and then to be replaced by lamellar bone. So the lamellar bone is having more mineral content, and because of that, what it is more stronger than the woven bone. So let's look at the options. It is the first type of bone to appear in embryonic life. Okay, this is going to be true. It is replaced by lamellar bone in adult life. So that is also true, is going to be replaced. It in adults, it is found near sutures in the skull. So where there is no replacement yet, that is where you're supposed to find it, because we know that in sutures we have not yet replaced that portion, right? And then it has the same mineral content as lamella. This is not true, because lamella is supposed to be more stronger than the compact, so you don't expect this one to be true. Okay, and then number 31, in intramembranous ossification. Now before even answer the question, intramembranous ossification is where bone is developing from mesenchymal tissue direct. It's different from endochondrial, where bone is developing from already cartilage that is already present. So what are the steps? The first thing is that you are going to have the mesenchyme. Mesenchyme is just embryonic tissue. This mesenchyme is going to differentiate and give you osteoprogenitor cells. And then these osteoprogenitor cells, what is going to happen is that they are going to be invaded by blood capillaries. When invaded by blood capillaries, now they are receiving nutrition, and then osteoblasts will be able to develop from the same osteoprogenitor cells. So we have got now osteoblasts. These osteoblasts which have developed can now secrete, they produce now what is known as osteoid. Osteoid is just an organic matrix. And this osteoid is going to undergo mineralization. It starts to gain minerals, things like calcium, meaning it's now becoming strong. Okay. and then it undergoes mineralization. After that, collagen also starts to form. Collagen will also start to form. And then after that, now you are going to have the osteoblasts, some of them, because after you have formed minerals, not all the osteoblasts are going to be converted to osteoid or produce osteoid and then become mineralized. Those which are going to remain are going to be trapped in some form of, let's say, we call them lacunae. They are going to be trapped, and those which are trapped, those osteoblasts which are trapped, now become known as osteocytes. So this is a process of intermembranous ossification. Okay, so mesenchyme cells differentiate into osteoprogenitor cells. This is correct. There is replacement of hyaline cartilage by bones. The replacement of hyaline cartilage, that is endochondral ossification. In cranial flat bones, the bone in the center forms faster than the periphery. So that is not true. Okay, you are supposed to be actually forming the opposite direction. Osteocytes lose their contact with each other once bone has developed. Of course, it might be true in some case, but really not too true. They will not all lose contact with each other because some of them will be together and then they'll be trapped in lacunae. So the answer is A. Fetch 2. Which of the following is not correct regarding trapezius muscle? It is a flat diamond shaped muscle. Okay, we know that of the trapezius is, yes, diamond shaped. So let me put a tick there. Okay. It is innervated by the dorsoscapular nerve. Is that true? Now, the trapezius muscle is not innervated by dorsoscapular. Instead, it is innervated by the accessory nerve, that is cranial nerve number 11, and also the anterior rami of C3 to C4, right? And these will be the ones which will be giving its sensory innervation to be able to feel the pain. The accessory nerve will be for motor. It sends its receptor fibers via C3 and C4. That's what you've just said. For it to pain or sensory innervation is by anterema of C3 and C4. It makes up the superficial group of muscles of the back. This is also true. One of the superficial back muscles is the trapezius muscle. So the answer is this one. That's the one which is not correct. To which of the following muscles of the back is the thoracodorsal nerve immediately deep? We have got the latissimus, trapezius, rhomboid major, rhomboid minor. Now we know that the thoracodorsal nerve innervates the latissimus dorsi, so it's going to be immediately deep to it. So that is A. Number 34. Loss of patellar reflex and cutaneous sensation of the anteromedial side of the leg indicates damage to spinal nerve dash. So the loss of patellar reflex and cutaneous sensation. Cutaneous sensation, if you look at this one, the patella is here. Patellar reflex is where you are hit on the patella here and then you are able to feel, you can move your leg like that. So you can see what innervates most of this region where the patella is. And also the question is saying also cutaneous sensation of the anteromedial side. And anteromedial side of what? This is of the leg. You can see this is the anteromedial side of the leg. What is the innervation there? So we have got the infrapatellar branch of the saphenous nerve, and that is L3 and L4, right? And then if you come now also the other side to finish up the patella, you have got L4 and L5, meaning that for the patellar reflex is basically L4, right? And also inframedial, the medial anteromedial side of the leg is also being innervated by L4 there. Okay, so the answer is going to be L4. Which of the following muscles is not a medial rotator of the leg. Now, if you are talking about muscle being a medial rotator of the leg, say here is our leg. Okay, something like that. So muscles, let's say this is the midline is going to be here. You have got another one this side. So muscles which are found this side are the ones which are going to be involved in medial rotation. Okay, medial rotation. Now one which is not a medial rotator. Semitendinosus is going to be a medial rotator. It's actually, it does rotate the leg medially because it's found more medially. Same with the semimembranosus. Now the biceps femoris is found laterally, so it's a lateral rotator. Gracilis is also a medial rotator, so it's the biceps femoris. Okay, this is what we are talking about here. This is the posterior end of the thigh. You can see the popliteal fossa here. So you have got the gracilis more medially. After the gracilis, you have got semimembranosus, and then you have got semitendinosus. So semimembranosus and semitendinosus, actually these ones also form the medial boundary of the popliteal fossa, the upper medial boundary of the popliteal fossa. And then the upper lateral boundary is formed by this muscle. What is the name? Biceps femoris. Actually, the biceps femoris is on the far end. Also here, the biceps femoris has got two heads. So this is the long head and also the short head there. And then the other boundaries of the popliteal fossa on the bottom. So the bottom medial boundary, you have got the medial head of the gastrocnemius, and then bottom lateral boundary, the lateral head of the gastrocnemius muscle. Okay, so we have seen the answer there. Molenga sustains an injury in the popliteal fossa during the tibial, injuring the tibial nerve. This might result in, now if you look at the tibial nerve, what happens that in the popliteal fossa you have got the sciatic nerve. When you just reach the upper part of the popliteal fossa, before the nerve comes out, it's going to divide into two nerves, the tibial nerve and the common fibula, which is also known as the common peroneal nerve. The tibial nerve will go on the posterior end of the leg and then it will go down there. And this one is going to have a lot of functions. And then the common fibula is going to turn. You can see it turns and goes to the front, right? It goes to the front of the leg. Okay, like that. So let's now answer. So there is injury to the tibial nerve. Which one do you expect to have? Now the first thing is, let's look at loss of evasion. Loss of evasion, is that going to be one effect? Now evasion mostly is not by the tibial nerve. Evasion, the tibial nerve will be involved in invasion, not evasion. This is common fibular nerve. Loss of a sensation between, so this one the option didn't finish, it just said between, we don't know between what. And then it's inability to stand on one's toes. Now okay, before I comment on this one, foot drop. Foot drop is caused by an injury to the common fibular nerve, not the common tibial nerve. If you're talking about inability to stand on one's toes, the toes, these ones are going to have innervation from, depending with the toe that you are talking about, from both the fibular nerve and the tibial nerve and the common peroneal, the common fibula. So we can say that is an answer because it does contribute also to the innervation of the toes. And so meaning that if there is no innervation to them, you cannot stand. Just like we saw here, look at this one. You can see here you have got the, okay, this is the fibular nerve. On top, the fibular nerve is the one which is giving sensations. On top, this is the skin. And then you have got the this is the sural nerve. Okay, the saphenous there. Okay, I can't see the fibular nerve here. Now, this is sensation, this is not motor. So you can see mostly what is giving sensation to the part of the leg on top here is the fibular nerve. Number 37, which of the following correctly, which of the following correct is correct about the fibular artery? Fibular artery. Now, before we even talk about the fibular artery, we need to understand the innervation and also the arterial supply to the leg and also just the thigh. So let me write the blood supply and also the innervation. Okay, starting with the thigh. Now, for the thigh, we're going to have the anterior compartment, the medial compartment, and the posterior compartment. Anterior, medial, and also posterior. Okay. So anteriorly, the blood supply to the thigh, the blood supply to the front of the thigh is by the femoral artery. Same with the innervation, the femoral nerve. Now, if you go medially, the blood supply is going to be the obturator artery. Same with the innervation, obturator nerve. If you go now posteriorly, the blood supply posteriorly is going to be by the profunda femoral artery or the deep femoral artery. And then if you go to the innervation of the posterior compartment of the thigh is going to be by the sciatic nerve. C is the thigh. And then if you go now to the leg also is going to be divided into the anterior compartment. You're also going to have the lateral compartment. So you have got anterior compartment, the lateral compartment, and also the posterior compartment. So looking at the innervation to the leg, anteriorly, what will innervate the front of the leg is going to be the deep peroneal nerve. Deep peroneal. Now, deep peroneal is also known as deep fibula. And then the lateral compartment is going to be by the superficial peroneal or the superficial fibula. And then posteriorly, it is this same nerve that you can see here, which is the tibial nerve. Because the one which is going in front and lateral is this one. So the deep one will go interiorly. The superficial one will remain laterally here. That will be the lateral peroneal nerve. And then now the blood supply on the anterior compartment of the leg. Anteriorly, blood supply is going to be by the anterior tibial artery. Anterior tibial artery. Which of the following is correct about the fibular artery? Supplies the muscles of the anterior compartment of the leg. This is true. Okay. And then passes have I even seen it correctly? About the fibular artery. Supplies the muscle of the anterior compartment of the leg. Okay. We have said the what supplies the muscle of the anterior compartment of the leg is the anterior fibula. But here they've just said the fibular artery. So take note of that. I've just ticked there anyway. And then B passes anterior to the interosseous membrane. Is it going to pass anterior? Remember that what we are talking about is the fibular artery. Okay, this is the fibular artery. And then usually becomes the dorsalis pedis, courses through the deep posterior compartment of the leg. Okay, so actually, because this is not anterior, I was supposed to say anterior tibial. The anterior tibial, this is where it becomes strict because anteriorly innervation is by the what? The fibular nerve. Fibular nerve, deep fibular nerve. But blood supply anteriorly is by the anterior tibial artery. The fibular artery is posterior. Okay, the fibular artery is going to be posterior here. So meaning that this option cannot be true. Supplies the muscle of the anterior compartment can't be true. And then passes anterior to the interosseous membrane. This one also is not true. is to be actually posterior, not anterior, because it's on the back. Usually becomes the dorsalis pedis. Now, this option, dorsalis pedis is an artery which is on top of the leg, I mean, of the foot. So it can be formed by an artery that is on the posterior, courses through the deep posterior compartment of the leg. This is the correct option, right? A tight plaster cast that exerted pressure on the head and neck of the fibula might result in loss of. So there is compression on the fibula. Should actually be like fibular nerve, even if it wasn't complete fibular nerve. So what is it going to result to? If you compress the fibular nerve, what is it going to result in? Loss of evasion. Remember what we had said? We said that evasion is by the fibula, while invasion is by the tibia. Look at this. We have said that fibula is this side laterally, and laterally we can turn the foot like this, and that is known as evasion. Actually, evasion is not turning it like that, but turning this part upwards, turning this part which is laterally a bit upwards, right? That is evasion. So that is going to be, because the problem with invasion is not by the fibula but by the tibia. Same with plantar flexion. Plantar flexion is where you move this leg downwards like that. You look at the innervation which is going posterior. What is that one? It's the tibia. So obviously it shouldn't be this one. Okay. Same with the flexion of the hallucis. What is going to the hallucis is not the fibula. Where would you feel for the pulse of the dorsalis pedis artery? Now, the dorsalis pedis, look at this. As we already mentioned, the dorsalis pedis comes from the anterior tibial artery. Okay, that is why that question we had said it couldn't be correct coming from the fibular artery, because the fibular artery is posterior. So this anterior tibial artery, when it continues, you can see it becomes the dorsalis pedis here. And the dorsalis pedis is passing in front of these bones. It will pass in front of the navicular. It will pass in front of the talus, on top actually. It is also going to pass on top of the intermediate cuneiform as it moves like that. So this is the one you can see here. So if you can see, this is the medial side, this is the lateral side. So the dorsalis pedis is medial to, look at this. This is a tendon going to these digits. So we call it does extension of the digits. This is on top. So extensor digitorum longus, right? So these tendons, we call them tendons of extensor digitorum longus muscle. They extend digits. So tendons of extensor digitorum is not brevis, longus. Okay, so the dorsalis pedis is medial to the tendon of extensor digitorum longus, but it is lateral to the tendon of the extensor hallucis longus. So I was saying hallucis because this tendon is going to the big toe. The big toe is known as the hallux. Okay, so it is lateral to the extensor hallucis longus tendon, and then medial to the tendon of extensor digitorum longus. Now let's answer the question. Where would you feel for the pulse of the dorsalis pedis artery? Direct superficial to the intermediate cuneiform. Is it true? We said yes. It does pass just on top of the intermediate cuneiform. Directly lateral to the tendon of the extensor digitorum longus. Remember we said the dorsalis pedis is medial to the tendon of the extensor digitorum longus, and then direct in between talus and navicular. We said that this artery passes on top, not between these two, but on top of the talus and the navicular bones. Direct medial to the extensor hallucis, supposed to be lateral to the extensor hallucis. So this is also not correct. Okay, so the best answer is A. The blood supply to the posterior compartment muscles of the thigh is by Remember what we said? Posterior compartment of the thigh. What did we say? Let's start. Anterior compartment of the thigh. The blood supply is the same as the innervation. That is from the femoral artery, femoral nerve. The medial compartment of the thigh. Blood supply is the same as innervation. Obturator artery, obturator nerve. But now the posterior compartment, the blood is from the profunda femoris, while the innervation is from the sciatic. So the answer is profunda femoris. The spinal cord segment that supplies cutaneous innervation to the bilateral side of the foot is, if we are talking about bilateral side, bilateral means both ends, right? So look at this. You can see this part of the leg or the foot is being innervated by S1 to S2. Okay. So S1 will be able to innervate this part of the leg. Same also with the other part of the leg, the other leg. It will also do that. So innervation to the bilateral side of the foot is by S1. I want you also to take note of the innervation between the big toe and the first toe here, which is not a big toe. That is by the deep peroneal nerve, L4, L5. Just take note of that innervation. You also need to know these cutaneous innervations because they can bring them for you to be able to label or something like that. The muscle that contracts to unlock the extended knee joint is the extended if the knee is straight like this. Okay, let's say the knee is straight. You want to extend it, you want it to bend here. What muscle should do that to unlock the extended knee? Popliteus, of course, the popliteus, though it is behind, but it will not be involved in strong extension, it is weak. Plantaris, okay, this is going to be correct, the plantaris muscle, okay. Actually, the plantaris is the one which is going to be weak in extension because it more comes from all this end like that, or from the plantar of the foot. So it's not plantar. It's supposed to be popliteus, the one which reaches on the popliteal fossa here. That's the popliteus. The medial head of the gastrocnemius will be involved more in medial rotation, lateral in lateral rotation. So these two can't be. So the answer is the popliteus muscle. Which of the following correctly describe the pectoralis major muscle? Pectoralis major muscle. It is made up of two parts, the clavicular and the sternocostal parts. This is really not true. The pectoralis major muscle has got different portions where it originates from. It will come, of course, from the clavicle. It will come also from the sternum. Also from it also has the abdominal part. So that can't be the best option you can pick. And then option B, it is superficially covered by the clavipectoral fascia. The clavipectoral fascia will not be superficial to this muscle. To be actually be deep because after this muscle are going to be having breasts. It is divided. It divides the axillary artery into the first, second, and third part. It's not the pec major, but pec minor, which divides the axillary artery into two, three parts. It is innervated by the lateral and medial pectoral nerves. This is true. Lateral and medial pectoral nerves coming from the lateral and the medial cords of the brachial plexus. With regard to the vagal nerve, which statement is true? Left vagus is anterior to the phrenic nerve. Okay, let's first look at this. You can see how they move. So for the vagus on the left will move like this. You can see it is passing in front of the arc of the aorta. it will send a branch, and that branch will be able to round the arc of the aorta. That is known as the left recurrent laryngeal nerve. It goes to the larynx. And then this one is more anterior. Now the right one is more posterior. And for the right one, it does pass, it goes like that. It also sends a branch, but that branch rounds the right subclavian artery. And that is the right recurrent laryngeal nerve, which also goes to the larynx. Okay, so now let's look at the options. Left vagus is anterior to the phrenic. This is not true. The vagus is posterior to the phrenic. Left recurrent laryngeal hooks around the left subclavian artery. Now, the one which hooks around the subclavian is the right. The left will hook around the arc of the aorta, so it can be correct. Right recurrent laryngeal hooks around the ligamentum arteriosus. The one which will hook around the ligamentum arteriosus is really not the right, okay, but the same one which is rounding the arc of the aorta, which is the left. Left vagus passes posterior to the root of the lungs. This is the correct one. So when you have got the lungs, here you have got the hilum of the lungs. The vagus will actually pass posterior, and other structures pass posterior. What passes anterior to the root is just the phrenic nerve. Okay. Number 45. Where does the right sympathetic chain cross the diaphragm as it enters the abdomen? Now, to answer this one, we need to be able to see this. Here is the diaphragm. The diaphragm has got different openings. We have got the opening for the vena cava, so we call it the vena cava hiatus. What passes there is the inferior vena cava and the right phrenic nerve. The opening of the aorta, we call it the aortic hiatus. What passes there is the aorta itself, the azygous and hemiazygous veins, the thoracic duct, aortic plexus, and some lymphatics. We also have the esophageal hiatus, where the esophagus will be able to pass. Also the anterior and posterior vagal trunks, those same ones which we are from talking about, which we are rounding the arc of the aorta and the subclavian. And also the phrenico-abdominal branch of the left phrenic nerve, the branch that is going to the to the abdomen. And also the esophageal branch of left gastric artery, and also the esophageal tributaries of the gastric vein. You also have the foramen of Morgan. Okay, so what to be able to pass through this foramen of Morgagni, you have got the internal thoracic artery and veins. Now, you also have an opening on the posterior end. On the posterior end of the diaphragm, that is where we're going to have the greater splanchnic nerves, lesser splanchnic nerves, least splanchnic nerves, the azygous and hemiazygous veins, not the arteries. These are veins, right? So that is it. Including also the sympathetic trunk will be on the posterior. So where does the right sympathetic chain cross the diaphragm as it enters the abdomen? It is through the posterior to the diaphragm. No, it is not through the aortic hiatus. It's not through the opening of the inferior vena cava, not through the esophageal. Okay. Which of the following is correct concerning coronary vessels? Coronary vessels, this is a blood supply to the heart. When you're talking about the coronary vessels, the right coronary artery always supplies the SA node or the sinoatrial node. This is not true. The SA node is going to be supplied by both the right coronary artery and the left. The right, of course, is the major blood supply, 60%, while the left will give 40% of the blood supply to the SA node. Coronary sinus is the only vessel that drains the heart walls. This is not true. The heart walls can also be drained by the anterior cardiac veins directly without going to the coronary sinus. We also have the Sebacean veins which go directly into the heart. The coronary veins drain into the inferior vena cava. This is not true. They'll go direct to the heart. The left coronary artery partly supplies the right ventricle. This is true even if it is the left coronary artery. It will also go to the right ventricle because it does turn on its route. Which of the following is not a characteristic of the pericardium? It has a serous part. This is true. The pericardium is going to have a serous part. Pericarditis may cause accumulation of fluid in the pericardial cavity. Okay, this would also be true. And then the visceral pericardium is the innermost layer. This is true even as we can hear visceral. Visceral meaning it is the one which is now surrounding the actual heart. So it's the innermost layer. The parietal is going to be outside. The fibrous pericardium is supplied by the vagus. Now the fibrous pericardium, no, it's actually going to be supplied by the phrenic nerve. So the pericardium is going to be fibrous, which is the outermost layer, and then you have got the serous. The serous layer is also going to be further divided into, you are going to be having now the visceral layer and the parietal layer. The visceral layer is also known as the epicardium. Number 48. Which of the following organs is likely to be compressed in a patient with abnormal dilated left atrium? If the left atrium is dilated, you expect the esophagus to be the one which is going to be compressed. And that is known as megalectrensis, where you have got the left atrium being dilated like that, and then it compresses on the esophagus. When the esophagus is compressed, you are going to have a condition which is known as dysphagia, where you have got difficulty in swallowing food because the esophagus has been compressed. 49. In the posterior triangle of the neck, the scalenus medius is superior and everything. So before you answer this one, I want us to look at it. This is the posterior triangle of the neck. You can see on the muscles, first, the anterior wall of the posterior triangle of the neck is, the anterior wall is by the posterior wall of the sternocleidomastoid, or the posterior border. And then the posterior border is by the anterior border of the trapezius muscle. And then we have also the bottom, which is covered by the by the clavicle there. When you talk about the muscles, the uppermost muscle is the semi uh, all right. So when we talk about the muscles, the uppermost muscle is a semi-spinatus capitis. The muscle below it is the splenius capitis, and then you have got the levator scapulae, and then you have got now the scalene medius. The scalenes are going to be the three. Are going to have the medius, the posterior, and the anterior. You can also see you also have nerves. Okay, you have got a nerve which is going to be running on the border of the sternocleidomastoid, that is the accessory nerve, cranial nerve number 11. You have got also the lesser occipital nerve, a bit running on the border of the sternocleidomastoid. This one I said sternocleidomastoid is not a sternocleidomastoid. I mentioned that was an error. And then you are also having the greater auricular, which is going to the ear. And then you also have the transverse cervical. Okay, it's transverse. Just how to remember that is immediately you see something like running horizontal, that's the transverse cervical. Okay, so these are the nerves. You also have these nerves which are going down. These are supraclavicular nerves, they are on top of the clavicle. So the scalenius medius is superior to the levator scapula. This is not true because the elevator is the one which is on top. The trunks of the brachial plexus are in between the scalenus anterior and medius. This is true. Apart from the trunks of the brachial plexus, you also have the subclavian artery also being between the scalenus anterior and scalenus medius mass. The same spine, spinetis capitis is inferior to the splenius capitis. This is not true. It's actually supposed to be superior. Accessory nerve emerges below the midpoint of the posterior border of the sternocleidomastoid. That is also not true. You can see the sternocleidomastoid here. Is it coming out on the midpoint? Really not. Okay. Mr. Munalula comes to the hospital with a swelling on the left upper lateral part of his back. Left upper lateral part. On examination, you find out that it is winged left scapula. Which of the following nerves is likely to have been affected? Every time you talk about winging of the scapula, you should be able to think about the long thoracic nerve. You have a patient with a stab wound immediately above the medial third and left clavicle of the left clavicle. Which of the following are you worried about? So we've been told there is a stab where on the medial third of just immediately above. So let's say we are talking about the left clavicle. Say here is the clavicle, and then the stab is on the medial third. Say the medial third is somewhere here. Okay, because we're talking about medial, here is the midline. Just above, so just on top, somewhere here, okay, on the left clavicle. Which of the following are you worried about? Injury to the trachea. Now, the trachea will not be it because the trachea is more on the midline. Pneumothorax. Pneumothorax is where the knife went into the lungs and then the lungs had to collapse. Now, we don't think much of this one because the lungs end just slightly above the first rib, just slightly above the first rib, and the first rib is below the clavicle. So if the lung, let's say, ends here and the knife was on top, there are so many that you have not hurt the lungs. Perforation of the superior vena cava. Really not about the superior vena cava because that is again a bit of high and lateral, something like that. Injury of the trunks of the brachial plexus. So the trunks of the brachial plexus, when they come out of the neck, they'll go like that. So you're expecting that you are going to injure them at this point. So this is the best that we can pick. Which of the following is not a normal constriction of the esophagus? Now, the esophagus is normally constricted at 3 points, where it is going to be passing from the thoracic to the abdomen in the diaphragm is going to be constricted, and also where the trachea is going to be bifurcated into the left and right principal bronchus. So there's also going to be a constriction there because these are going to be able to constrict on it. And also where you have got the pharynx forming the esophagus, changing into the esophagus, there's also a constriction. So the answer is going to be C. What is the order of testicular covering from the superficial going deep? Now about the coverings in the of the testis, the superficial most is the skin. After the skin, you are going to have the dartos muscle, okay, and then after that, now you're going to have the external spermatic. External spermatic. After the external spermatic fascia, you're going to have the cremasteric fascia and then the internal spermatic fascia. So which one is that? Skin, dartos muscle, external spermatic, cremasteric, internal spermatic. So that is D. Which of the following structures do you expect to find on the skin of a premature baby? Vellus, terminal hair, lanugo Now, normally, when a baby is growing up in the womb, the hair that a baby is going to have is known as lanugo hair. So if the baby is born prematurely, the baby will be born with this air. This air is going to be replaced by vellus air, and then the vellus air will be replaced now by the adult air, which is the terminal air. So the answer is lanugo air. Concerning skin glands, a 7-month-old fetus has functional sebaceous glands. Sebaceous glands only function at birth, not 7-month-old fetus. In women, eccrine sweat glands are affected by hormones. Remember, we said that eccrine sweat glands, these are going to be located in places like the axilla and also the external genitalia. They are actually affected by hormones. Also, hormones which include the absorption of some salts and water, okay, like the aldosterone. Apocrine glands are active from birth. This is necessarily not true. Okay. Eccrine sweat glands are straight tubular glands. This is not true. These ones are not straight tubular, but they are going to be branched. Moses twists Mary's forearm as they were playing. Which of the following sensory structures of her skin were able to sense the twist? Pacinian corpuscle, crow's end bulbs, Lufine corpuscle, Meissner's corpuscle. Now, if you look at these corpuscles, the Pacinian is involved in the feeling or sensation of pressure, and then high frequency vibrations. And then if you come to the crow's corpuscle, these ones are involved in feeling cold. They have got thermoreceptors for cold. And then the rufine corpuscle, these ones are involved in being able to notice a stretch. Apart from that, also some finger finger movings and those things. So they'll be able to notice that skin stretching, okay, finger pointings or feeling. And then the Meissner corpuscle, these ones are involved in feeling touch and also low frequency vibrations. So here one sensory structures of her skin which are able to sense the twist. So twist is some kind of stretch there. So that is the rufine corpuscle. Which statement is false regarding the heart? Now I just put this diagram here, it wasn't there. So the heart, you can see the anterior wall is this one, which is here. The base is posteriorly. Okay, the base of the heart is behind, a bit behind. And then the apex, you can see it is facing anteriorly and laterally. And then the bottom is the surface on the diaphragm. Also have the right pulmonary surface, the left pulmonary surface. The apex of the heart points anteriorly inferiorly to the left. This is true, anterior inferior to the left. The apex of the heart is completely formed by the left ventricle. This is also true. You have got the left ventricle here. Okay. The base of the heart lies on the inferior surface. Look at where the base is. The base is not inferiorly but posteriorly. The heart is obliquely oriented with reference to the median plane. If the median plane is here, the heart is oblique. You can see it goes like in this direction. Okay, so that is true. So the answer is C. Which of the following rightly describes the heartbeat? Ventricular systole precedes atrial systole. Ventricular systole is a contraction. So this statement is saying that the ventricles will first contract and then the atrium contracts. Is that true? Proceeds. Okay. Now to proceed is to come after, meaning that you start with the atrial systole and then the ventricular. Let me first put a dash there. The SA node depends on the brain to generate. This one is really not correct. The SA node does not depend on the brain to be able to generate impulses. The apex of the heart is the last one to contract in one beat. Is that true? The apex of the heart is the last one to contract. Okay, so when contraction is happening, first you are going to have the depolarization of the atrium, and then you are going to have the repolarization of the atrium, the depolarization of the ventricles, and then the depolarization is going to spread to the rest of the heart. So it can be the last one to contract, but yeah, so that is true. Rise in ventricular blood volume closes them. This is actually not true. It's not the last one to contract. Look at this. When the heart is oriented somewhere like that, depolarization is going to start here, and then action potential will be able to spread like this. Okay, because you have got package fibers going all the way up to there. So expect the ends where the Purkinje fibers are going to be the last one to contract. So that statement is not true. Rise in ventricular blood volume closes the mitral valve. So what happens is this. You know that between on the left side, say this is the left atrium, this is the left ventricle. Let me write the heart in a simple way. Okay, I just hope it will make sense with what I want to talk about. So say this is the left atrium, this is the left ventricle. Here is the mitral valve, here is the aortic valve. So what happens that when blood moves out of here from the left atrium, it goes into the left ventricle. When blood increases very much in the left ventricle, it will generate pressure enough which will push these valves, and then they're going to close and open these valves so that blood can be able to flow out. So rise in ventricular blood volume is going to close the mitral valve. This is a true statement. Okay, so meaning that ventricular systole proceeds, atrial systole is not going to be correct. Regarding the lymphatic system, cisterna chyli lies anterior to the body of L1 on the right side and posterior to the abdominal. This is true. Cisterna chyli is on L1. It is to the right of the midline and then posterior to the aorta. Thoracic duct enters the thoracic through the esophagus hiatus. We had said, can you remember what we had said? The thoracic duct to enter via the aortic hiatus, not the esophageal hiatus. Thoracic duct terminates at the union of the right and left brachiocephalic veins. Is this true? It will terminate where there is the junction between the left internal jugular and the left subclavian. The cisterna chyli has colorless lymph, really not. Which of the following? So the answer is A. Which of the following is not one of the many vessels that drain into the cisterna chyli? Now, cisterna chyli is going to be made up of the left lumbar trunk, the right lumbar trunk, and the intestinal trunk. And then it forms that dilation, the cisterna chyli, which also goes and forms the thoracic duct, which goes to the veins on the left venous angle, which is a junction between the left internal jugular and the left subclavian. So this one is one of the components which will make up the cisterna chyli. The right lumbar is also one of them. The intestinal trunk is also one of them. So this is not the answer. The mediastinal surface of each lung has a cardiac impression. Which of the following statements correctly describes this impression? Now we know that the heart is more concentrated on the left side. So if it is to give an impression on the lung, that impression is supposed to be more on the left lung than on the right lung. Why? Because the heart is more on the left side. On the right ventricle forms a shallow impression. Okay, that is not true. Like the right ventricle is somewhere here. Shouldn't have an impression on the lung. On the right lung, the deep impression is produced by the right atrium, even if the right atrium has an impression, but it's not deep because like the distance is far. There is a bit of a distance. And then on the left, a deep impression is produced by the left atrium. This is not true. What should produce an impression is the ventricle. So that is on the left, the left ventricle produces a deep impression. Okay, so that is it. And then 62. Which of the following is correct concerning cardiac innervation? Now, the innervation to the heart is via what is known as the cardiac plexus. Now, what makes up the cardiac plexus of nerves? The cardiac plexus is going to be made up of one, the superior cervical cardiac branch. This is superior cervical cardiac branch. This one is coming from the left sympathetic uh, trunk, left sympathetic. Apart from that, it is also made up of the lower or inferior cervical cardiac branch. But the lower cervical cardiac branch does not come from the left sympathetic, it comes from the left vagus. Left vagus. So this is what makes up the heart innervation. So so this is what we want to find out. Which one is going to be the answer here? So let's look at A. The superficial cardiac plexus is formed by fibers from all cervical ganglia. That's not true. Superficial cardiac plexus is formed by fibers from all the cervical sympathetic ganglia and the laryngeal. That's not true. The superficial cardiac plexus is formed by fibers from the left superior cervical sympathetic ganglia, left superior sympathetic ganglia, and the inferior cardiac branch of the left vagus. This is true. Superficial cardiac. Let's now go on to question 63. Which of the following is not true regarding the kidney? Now, before you can even answer this question, let's just look at the kidney. Here is the kidney. You can see it has got the cortex, which is the outermost part, and the medulla, which is made up of renal pyramids. At the end of a renal pyramid, you have got a renal papilla. So when the ureter is going into the kidney, it is going to reach this hilum. There is a space here which is known as a renal sinus, and then that is where like the pyramid begins to enter now the kidney. And then the pyramid is going to be divided into major calyces. Major calyces will further divide into minor calyces, which will go and more wrap the renal sinuses, right? Which is the end of the renal pyramids. And then the other thing that you need to know about the kidney here is that the cortex is going to go into the medulla, dividing the medulla into pyramids. So this part of the cortex which goes into the medulla is known as the renal column of Bettin. Okay. So now we can answer the question. Which of the following is not true regarding the kidney? They are retroperitoneal. That is true. They are retroperitoneal. Another thing that I've not talked about is the fascias or the coverings which make up the kidney. You have got first what is known as the fibrous capsule, which is the outermost layer, and then you are going to have the perirenal, also known as perinephric fat. This is not fascia but fat, and then you are also going to have the fascia of Gerota or Gerota's fascia. The fascia of Gerota is going to have a different name anteriorly. Anterior is known as the fascia of Todd. And then on the posterior of the kidney is known as the fascia of Zokada. And then after this, you are going to have now your kidney there. Okay. So the renal sinus separates the renal pyramid. Is this true? This is not true. What separates the renal pyramid is it not the renal sinus, but the renal column. You can see these columns are the ones separating the pyramids. The sinus is these spaces that you can see inside there, and that's not the one. The Gerota's fascia surround the fatty capsule. So after the Gerota's fascia, you have got another kind of fascia here. So this was the fat. Then you are going to have the perirenal kind of. Okay, you are going to have some kind of fat again before it can even surround the entire kidney. So this is true. The renal corpuscle are found in the cortex. This is true. The renal corpuscle makes up the nephron and those structures are involved in the making of urine. So the answer here is B. For a molecule to move from the bloodstream to the Bowman's space to become the glomerular filtrate, it passes through the following except. So here is your bloodstream, and you know that for the blood is going to have a part which goes like that, forming the Bowman's capsule. Okay, like that. And then you are going to have now not the Bowman's capsule but the glomerular. Then you are going to have this. Now for this blood vessel, we know that blood vessels have got what is known as endothelium. So one of the layers that have to be passed is the epithelium of the blood vessel known as the endothelium. And then now the part of the Bowman's capsule which is visceral or surrounds the glomerulus is made up of what we call podocytes. These are special epithelial cells, podocytes. Now the podocytes are going to have, so there's going to be what is known as a slit diaphragm here, some openings. Okay, like if you have got one podocyte, another podocyte, they will leave some slits, those openings. That is where the contents will be able to pass. Contents don't pass through the podocytes themselves. Okay, so these are some layers that have to be passed. Now, of this layer that you can see, this is a parietal layer. There is also a visceral layer that has to be passed. So there are basically three layers: the endothelium, the slits, and also another layer. Okay, so because you are also going to have a basement membrane at this point, the basement membrane where the blood vessels are lying, the basement membrane also where the endothelium, the blood vessels, the podocytes, I mean, are lying. So we don't pass podocytes, but we pass through the slits, which we call as the slit diaphragm. Also the endothelium. You also have the fused basal lamina of capillaries and visceral layer of the Bowman's capsule. So the visceral layer of the Bowman's capsule, that is the layer that is surrounding these capillaries. Okay. Concerning concerning function of the juxtaglomerular apparatus. Now the first thing we need to know about juxtaglomerular apparatus, the juxtaglomerular apparatus is made up of three parts. It's going to be made up of juxtaglomerular cells, which are going to be able to secrete renin. It's also going to be made up of macular denser cells, and the macular denser are involved in the sodium absorption. It's also going to have some other cells which are known as Lassis cell or Purkinje cells, which are made up of mesenchymal, which are basically mesenchymal cells. And these ones secrete what is known as erythropoietin, which is involved in the making of red blood cells. So which of the following structures is not a characteristic of the visceral part? Okay, so before this we are on top. Concerning functions of the JGA, juxtaglomerular apparatus, all the following are correct. It produces renin, this is correct. Produces angiotensin. Angiotensin is not produced here. It's actually produced in the liver as angiotensinogen, and then it to be converted to angiotensin 1. Involved in autoregulation of glomerular filtration rate. Okay, this is also, is this one correct? Involved in autoregulation. This is true of the glomerular filtration rate. That's what we're talking about the sodium reabsorption in case the glomerular filtration rate is not okay. Located in the distal proximal convoluted tubule. This is also true. So what happens that if this is your blood vessel, and then you have got your capillaries there, and then they go like that, and then you have got your Bowman's capsule, and you have got this one which surrounds. You're going to have the loop of Henry, and then it goes, of course you have the proximal convoluted tubule, the loops of Henry, and then it goes like that. Now, the distal convoluted tubule, there's going to be that part of the distal convoluted tubule which touches with the efferent arterial. This part. This is where you are going to have the formation of the juxtaglomerular apparatus. Which of the following structures are not a characteristic of the visceral part of the Bowman's capsule? Now, the visceral part of the Bowman's capsule is that part that is involved in the filtration. So you have got podocytes with their primary processes and pedicels, which are like their legs, their extensions. So except vesicular pore. This is not a pore that has got blood. Okay. It has got all these as their characteristics. Which of the following cells in the kidney are involved in the process of red blood cell production? So we had said mesenchymal cells produce erythropoietin, which is involved in red blood cell formation. 68. Which of these is not a function of the kidney? Regulation of acid-base balance, this is true. The kidney can secrete extra protons. Secretion of angiotensin 1. The kidney is not involved in secretion of angiotensin 1. So how is the process then if it's not involved? So what happens that if there is a fall in blood pressure as going to be noticed by juxtaglomerular cells, the juxtaglomerular cells are going to be able to produce renin. And when this renin is produced, the liver produces what is known as angiotensinogen. Angiotensinogen now will be converted by renin to angiotensin 1. Where is angiotensinogen produced? In the liver. Angiotensin 1, what will happen is that it will also be converted to angiotensin 2. Now, angiotensin 2 will work. Now, what converts angiotensin 1 to angiotensin 2 is angiotensin converting enzyme, and this one comes from the lung. So you can see three different types of tissue: lung, kidney, and also the liver working together. Angiotensin 2 now will be the one which will be involved in a lot of things to make sure that it restores the glomerular filtration rate. Activation of vitamin D is now question number 69. Which of the following structures are not found in the renal corpuscle? The renal corpuscle is just made up of this the glomerulus and also the Bowman's capsule. You are also going to find some kind of connective tissue, which is like so you have got podocytes there. These are the ones which will be able to line the glomerulus. You also have capillaries, which are these on the Bowman's capsule. Now the macula densa is on the distal convoluted tubule, so that is not part. You also have mesenchymal cells. Mesenchymal cells, this is just connective tissue that you are going to be able to find here. Okay, so meaning the answer is going to be macula densa. And then 70. Concerning the structure of the male reproductive system. So before even answer the question, I just put this picture here so that we can see. We can see we have got the corpus spongiosum. The corpus spongiosum, we are starting at the bottom here, at the beginning on the pelvic bone, as a bulb of the corpus spongiosum. And then as it goes at the end of the corpus spongiosum, we have got the glans penis. And then it's in the corpus spongiosum that where we have got the urethra passing. And then we have got two corpus cavernosums. So let's answer now. The urethra passes through the corpus cavernosum, that is not true. It passes in the corpus spongiosum. The penis has paired corpora spongiosa, that is not true. The ones which are paired are the corpus cavernosum, not spongiosa. The glands extend from the corpus spongiosum. You can see that is true. Erectile tissue of the penis is made up of skeletal muscle. These are not skeletal muscle, it's just tissue. Which of the following structures have a lot of stereocilia in their epithelium? Now we know that epidermis and vas difference, or the ductus difference, have got stereocilia, but the one which is more abundant is the epidermis. Which of the following is incorrect regarding story cells? Which one is incorrect regarding story cells? They extend from the basal lamina or the luminal surface. The spermatids are invaginated into the story cells. They produce follicle stimulating hormone. They phagocytose excess cytoplasm from the spermatids. So which one of these is, we want which one? Which is incorrect. Okay. So they extend from the basal lamina or the luminal surface. This is true. When you look at the seminiferous tubules, at the bottom you are going to have the Sertoli cells which go like that. They are long cells, alright? The spermatids are invaginated into the Sertoli cells. Yes, the spermatids are going to be found within the Sertoli cells. Spermatids are sperms, which of course have differentiated, but they are not fully functional. They produce follicle stimulating hormone. This is not true. Follicle stimulating hormone will stimulate them to make sperms in spermiogenesis or spermatocytogenesis, but not them producing follicle stimulating hormone. They phagocytose excess cytoplasm. This is true for it to be able to form a functional sperm, because normally when a sperm is formed, it's going to have excess cytoplasm like that. So all this cytoplasm has to be removed so that it remains a functional protein with a tail like that, a functional one. Okay, so the answer is C. Which statement is true concerning seminal vesicles? They produce 30% of the ejaculate. This is not true. They actually produce about 70 to 80% of this of the ejaculate. The fructose in its secretion coagulates the semen after ejaculation. That's not true. The function of fructose is for energy provision, not coagulation. Prostaglandins in its secretion stimulate activity in the female. This is true. What happens is that because when sperms go into the female reproductive system, they might be considered as foreign. So the prostaglandins are there just to make sure that they are not treated as foreign, so they are not destroyed. They store sperm, not them. What is the name of the capsule that's around the testis? Testis is surrounded by tunica albuginea. Maturation of spermatozoa occurs in the, if you just hear of maturation of spermatozoa, it will occur in the epididymis. Okay, not anywhere else, epididymis. 76. Which of the following cells are not found in the interstitial tissue of the testis? In the interstitial tissue of the testis. In the interstitial tissue, you are going to have fibroblasts. You also have these myoid cells, also have Leydig cells. Sertoli cells are not found in the interstitial tissue. Which of the following cells of the testis produce the hormone testosterone? Now, testosterone is going to be produced by Leydig cells, right? Testosterone by Leydig cells. During penile erection, we already talked about what Sertoli cells do. Sertoli cells are involved in the process of making sperms, not making the male sex hormone testosterone. During penile erection, which nervous system causes vasodilation? Now, for an erection to happen, you need blood. And what you can use to know how this happens is when the penis is erected, it points, right? It's pointed. So think of the point as parasympathetic, and for the penis to point, you need to the blood vessels to vasodilate so that more blood can go to it. And pointing is parasympathetics, the P parasympathetic, and then to shoot, that is to ejaculate. So ejaculation, you can say S, shoot, that is controlled by the sympathetic. So vasodilation is parasympathetics. Which of the following is correct? Luteinizing hormone stimulates body cells to release testosterone. Is that correct? That is not correct. Supposed to be not luteinizing hormone. Okay, that should be FSH. Follicle stimulating hormone stimulates Leydig cells of the interstitium. Is that true? That is also not true. Testosterone stimulates Leydig cells in the seminiferous tubules. So that is correct. Okay, this statement is correct. Okay, let me look at it. Actually, not. Testosterone stimulating Leydig cells in the seminiferous tubules. That is not true. Inhibin produced by Sertoli cells cause reduction in FSH. This is now the one which is correct. What happens is that Sertoli cells will be able to produce inhibin. Inhibin will inhibit follicle stimulating hormone. Okay, it inhibits follicle stimulating hormone. Which of the following organs is considered as a primary sex organ in males? Now, in males, the primary sex organ is the testis. In a female, the primary sex organ is going to be the ovary. 81. Concerning seminiferous tubules of the testis. Seminiferous tubules. So if you can see, I just put down this diagram. You have got the testis here. These things that you can see here, those are going to be the seminiferous tubules. That's where there is a formation of sperms. And then they are going to be able to come together like that, and then it becomes known as the epididymis. The epididymis will go like that. At the end of the epididymis, it is dilated and is known as the ampulla. Epididymis will be able to join also with the seminal vesicle, drain their contents there into the urethra. And then you also have the bulbourethral gland there, which also drain its content, and then before it can come out. The question is, what is true concerning the seminiferous tubules? Converge to become epididymis? That's not true. Of course, when they come together, it's not them which like will form they become the epididymis. No. Okay. They are lined by simple cuboidal epithelium. How about that one? That is not true. They are going to be lined up by what is known as is it stratified germinal epithelium, and then C, basement membrane covered by skeletal muscle fibers. That's not true. They produce spermatozoa. This is the function of seminiferous. Concerning the vast difference, enlarged portion is called the ampulla. This is correct as we saw, lined by simple epithelium with stereocilia, simple cuboid. This is not actually pseudostratified columnar, which is having stereocilia. Sperms are stored in the distal portion. The distal portion is where they are going to be removed from, so not stored. Enters abdominal cavity via pubic arch. They will use what is known as the inguinal canal. Which of the following hormones is responsible for ovulation? Now, to ovulate, what is needed is luteinizing hormone. What gland in males is homologous to greater vestibular glands in females? Greater vestibular glands are also known as Bartholin's gland, and they are equivalent to the Cooper's gland in a male. Female reproductive system. The epithelial cells of the uterus have microvilli. Really not of the uterus. Uterine tubes epithelia cells are ciliated. They do have cilia, that is what pushes the egg. The uterine glands are simple tubular. They are not simple tubular but branched tubular. During menstruation, pars functionalis of the endometrium is not lost. The endometrium has got the basal layer and the functional layer. The functional layer is going to be lost during menstruation. The basal layer is the one which still maintains it and also has a blood. In which of the following structures does fertilization occur? Fertilization is more likely to occur in the ampulla. The following joint is a syndesmosis. Now, when we are talking about joints, joints can be divided or classified into anatomical joints and the physiological joints. Every time we hear of physiological, then we are looking at the function that they perform. Anatomical, it is structure. Now, the anatomical joints, let's start with the physiological joints. Looking at their function, you have got those joints which can move, those which cannot move, those which can only allow some movement. So I've got synarthrosis. These ones are immovable. And then we have got amphiarthrosis. These ones are slightly movable. And then we have got diarthrosis. These ones are really movable. So we can give an example for synarthrosis like sutures, they cannot move. Antiarthrosis, those which can slightly move. And then diarthrosis, they can really move, like the elbow and those others. And then anatomical classification, we can classify these joints as being fibrous or cartilaginous or even being synovial. These are the three classifications. Now, on the fibrous classification, these ones, they are just made up of uh, fibro cartilage or fibrous tissue, and these can be divided further into sutures. Sutures, these are ones which cannot move in the head. They can be divided into a gomphosis also. Gomphosis, this is a fibrous joint which is found on the teeth. The teeth anchored to the jawbone by gomphosis. They cannot move those. Same with the suture. So fibrous joints are equivalent to synarthrosis, which can't move. And then you also have what is known as a syndesmosis. Now, a syndesmosis is a joint that is found where you are going to have some kind of a tough tissue connecting bones. For example, when you have got the tibia and the fibula, these are going to be connected by a strong tissue here. So this joint is a syndesmosis. And then cartilaginous joints, these ones are going to be divided into primary cartilaginous joints and secondary cartilaginous joints. The secondary cartilaginous joints is also known as the symphysis. Okay, symphysis. And then the primary cartilaginous joints, this is also known as the chondrosis. And the chondrosis can be either permanent or temporal. So the permanent one does not ossify. An example that we can give is a joint, the first sternocostal joint between the first rib and also the sternum. That does not ossify. And then the temporal chondrosis includes on the growth plate. It can actually ossify. And then the symphysis is like, you can give an example of the pubic symphysis, which is on the pubic bone. And then the synovial joints, these ones can be divided into six. We are going to have a plane joint, which is also known as a gliding joint. So here bones glide over each other. They slide over each other like that. And an example that we can give is a joint between the clavicle and the scapula. And this joint is unidirectional. It just moves in one plane, either up or down like that. They can just slide on each other. The other one is the pivot. We know how a pivot is. So a pivot joint, an example that we can give, these ones they can barely shake, right? They can actually shake. It forms a pivot. A pivot is something that can think of it. You have got a plank here, and then you have got something like this. It can either move like this or move like that. An example that we can give is the joint that allows us to nod yes with our head, or no with our head, not really yes, no, up and down. This is also a unidirectional joint. We also have another joint which is a hinge joint. A hinge, think of the door. That's a hinge. It can either go, it can just turn 90 degrees. And an example of a hinge joint is on the elbow. It can go beyond. Okay, this one is also unidirectional. And then you also have a saddle joint. Now, a saddle joint, an example that we can give is a joint on the thumb. This one is bidirectional. You can try to move your thumb, it can go at least in different directions, but it is limited on rotation. That's a saddle joint. And then another joint is known as ellipsoid, which is synovial. Let me write here, ellipsoid. Ellipsoid is also known as condyloid. An example that we can give is on our wrist. The wrist can also at least turn, but there is limited rotation, but it can at least move in different directions, though there is limited rotation. And then the last one is a ball and socket, which is multi-direction. It can move in any direction. For example, on the shoulder joint there, okay, and also the hip joint. So, syndesmosis, what have we said? It is a type of where did I even write? It's a type of cartilaginous joint which is found between strong tissue. For example, a bone and another bone connected with strong tissue. So distal tibiofibular, this can be a syndesmosis. Proximal tibiofibular, that can be a syndesmosis, but mostly it's a distal where the tibia and the fibula ends there. You are going to have a strong membrane which will be able to connect those two bonds. So this will not be it. So the answer is going to be A. The sternal angle of Lewis is an important anatomical landmark on the sternum that can be used to count ribs. What is the vertebral level? Sternal angle is T4, T5. Which of the following statement is correct about the Navy irrigants? Now, the Navy irrigants is also known as the sacrosplanchnic nerves and the pelvic splanchnic nerves. Now, pelvic splanchnic nerves come from S2 to S4, and these ones are made up of preganglionic fibers. They are also made up of parasympathetic fibers and also some visceral efferent fibers. So consists of somatic, it's not somatic, okay? It doesn't go to muscles or it's visceral. It goes to internal organs, like organs in the perineum. So this can't be correct. Consists of postganglionic. Just post means this is not correct because it's made up of preganglionic nerve fibers responsible for motor supply to the detrusor muscle. Okay, it does go to organs which are found in the perineum, so expect this one also to be correct. Supplies external urethral sphincter. So for this one, there is a question mark there. But in case it is, but not external urethra. Maybe if we had said internal urethral sphincter, because external is involuntary, it's just up, you don't control it. Okay, you don't control it. It's supposed to be the internal that you do control.